But what happens when somebody smokes cigarettes? What are you guys worried about in this patient? COPD, right? So important topic of interest for the boards is going to be COPD, right? When it comes to COPD, what are your two main different entities that you have for COPD? You have emphysema, okay, and chronic bronchitis, okay. What is the difference? So if I draw the lungs like this, okay, what is the difference between emphysema versus chronic bronchitis? Emphysema is going to be more of hyperexpansion of your lungs, whereas chronic bronchitis is more to do with inflammation and having infection. You're going to have a lot of cough and sputum production. When you have a more cough, sputum production presentation in your patient, that's going to be more chronic bronchitis. Emphysema is going to be more hyperinflation of the lungs. So why does somebody develop emphysema to begin with? When you think of emphysema, right, why does it happen? Imagine you had alveoli, right, like this, right? So normally your alveoli looks like a bag of grapes, right? And these bag of grapes are essentially made because of septation that's present, right? Who typically gets emphysema classically? Is it smoking or is it somebody else? Huh? If it's a non-smoker, who gets emphysema? Alpha-1 antitrypsin, right? So if you have alpha-1 antitrypsin deficiency, those patients are going to get emphysema. Why? Why do you require alpha-1 antitrypsin for? In the air that you typically breathe, is the air clean? No, it's not clean, it's dirty. So whenever you breathe dirty air that comes into the lungs, what happens is you're going to get neutrophils getting recruited to come into the lungs, right? Because whenever you breathe in something bad or it's irritated to your lungs, you get an inflammatory response. Neutrophils is going to come there. And what does neutrophils release as a result of this? They release something known as elastase. Okay? They release something called elastase. Now this bag of grapes, which is alveoli, they're connected by septations. Guess what they're made of? Elastin. They're made of elastin. So if this elastase is going to break down the elastin, what's going to happen? Your bag of grapes like this, the septations are going to get broken down and now you've got one large big pool, right? That's how you actually develop emphysema. Make sense? So if you look at an alpha-1 antitrypsin deficiency patient, typically it does not have to be a smoker, it's a genetic problem, right? What do they typically present with to begin with? Would they come with a lung problem or something else?
Liver.
They will come with the liver problem. Why? It's what?
Builds up in the liver.
It builds up in the liver. Where is alpha-1 antitrypsin actually produced? It is produced in the liver, it is secreted into the blood and it comes to the lung. And what is alpha-1 antitrypsin's job? Is to block elastase enzyme. That's what alpha-1 antitrypsin does. It inhibits elastase enzyme and prevent elastase from breaking down your elastin. But typically alpha-1 antitrypsin is produced in the liver. The problem with alpha-1 antitrypsin deficiency is not much of a production problem. It's a problem with releasing it out of the liver. So if you're not going to release it out of the liver, what's going to happen? You're going to accumulate alpha-1 antitrypsin within your liver. Is that a problem if you accumulate too much alpha-1 antitrypsin within the liver? Why is it a problem? Alpha-1 antitrypsin is actually a glycoprotein. If you accumulate too much glycoprotein within your liver, what does glucose like to do? Invite water. So whenever you have glycoprotein accumulation, you're going to bring water inside, your liver is going to swell up and it's going to get destroyed and you'll end up with liver cirrhosis. That's why you end up with liver problems first and eventually you'll end up with emphysema. But typically if somebody's got alpha-1 antitrypsin deficiency, you'll have more of a pan-SNR emphysema. So why does a smoker develop emphysema? The story is important because you want to understand why does it happen in a smoker. They don't have alpha-1 antitrypsin deficiency, do they? They don't. No. So imagine if somebody's smoking, most people are smoking 1 pack, 2 packs, 3 packs a day, right? If you're constantly smoking all the time, right? You're constantly irritating your lungs, you're constantly bringing in neutrophils and the neutrophils are constantly releasing elastase, right? Can you run out of alpha-1 antitrypsin? Yes, you can. So what happens is you will develop a relative deficiency of alpha-1 antitrypsin because you're constantly stimulating the neutrophils to release these enzymes. That's why you end up with emphysema in a smoker, because you're depleting it because it's getting used up. Got it? So that is emphysema. And then chronic bronchitis is more a process where you actually have inflammation and then you have infection, and basically you'll have a lot of secretions present. That's the most important thing. So when it comes to the boards, when somebody comes with COPD symptoms, we know our classic patient, they'll have a smoking history. They're going to come complaining saying, hey, I've been having this cough, I don't feel so well, I'm bringing up a lot of sputum. And when you have a auscultation on them, what is your classic exam finding? You will hear wheezing, right? Most of your COPD exacerbation patients are going to have wheezing. So say a patient comes and you're suspecting this patient has COPD. Say it's coming to the clinic, right? How are you going to diagnose the patient to actually have COPD? Not subjectively by your gut feeling, but objectively.
PFTs.
You're going to do? Is it PFTs that you want? Yes, you want to PFTs, but what exactly are you looking for in it? In order for you to define specifically this patient's got an obstructive lung disease. Yes, so spirometry is what you're going to do. Okay, you do a spirometry, and what you want is an FEV1 over FVC ratio. It has to be less than 70. And now remember, this is post bronchodilator. That's important. It's not pre-bronchodilator, but post. So you have to give them a bronchodilator. So do post bronchodilator, and then it should be less than 70. Okay, that's what's going to be important, right? So that's how you're going to diagnose a patient with COPD when they come to the clinic. Okay, say moment you have a patient, you're like, okay, this patient most likely has COPD, and you did your spirometry and you diagnose them. What else are you supposed to do in this patient at this point? Anybody with a first time diagnosis of COPD, what else do you need to do?
You have to test for the antitrypsin deficiency.
So at least one time you have to test them for alpha-1 antitrypsin deficiency. Yes, okay, but that's not very important. You still have a lot of basic stuff you need to do before you think about alpha-1 antitrypsin. Every single person with a first time diagnosis of COPD, what are you going to do?
Smoking cessation.
Okay, before you can give them smoking cessation, but you need to do a couple of tests. Okay, because you need to classify once you call it COPD, what is your next step? You want to classify your COPD to see what stage they actually fall into. You don't need a CT scan. Everybody who smokes will require a low-dose CT scan for lung cancer screening, yes, but not for COPD. You don't have to just... Thank you for watching. If you like our content, please like this video, subscribe to our channel, and hit the bell icon so you get notified when a video is released every week. Have fun studying. We'll see you on the next one.